How are you?
Hello, how are you, Dr. Shakib?
Thank you very much.
Good evening.
Thank you for accepting our invitation to this joint meeting. I think we have 5 minutes, and we are waiting for the moderator of this panel, Dr. Khami. He will join us in few minutes.
That's great. Thank you very much. Maybe during this time, during these 5 minutes, we can ask our participants, whoever wants to have a ice-breaking talk, they may turn on the video, their microphone, and give us some welcome speech.
Yes, great, great.
What am I going to ask? I'm going to ask whoever can, please turn on your videos. And if necessary, maybe my colleagues can help you to do that.
Yes, please, all the participants, please turn on your webcam and join Professor Nekufar.
Okay, I think Dimitro is the first one. Am I right, Dimitro? Did I pronounce your name correctly?
Hi, dear Professor.
Hello there, how are you?
Hi, thank you for accepting our invitation, and I want to say hello to other participants as well for joining us in the first joint webinar between Dental School of Tehran, University of Medical Sciences, and Kharkiv National Medical University. I hope you enjoyed this 2 days program and learn from each other.
Okay, so let's start by having another word from Dimitro. Dimitro, did I pronounce your name correctly?
Hello. Okay, it's right. I'm glad to see everyone. It's a new experience for me because I never attend international courses, if we can call that name. No, I'm student. I'm second-year student of Kharkiv National Medical University, and I hope that our meetings can get me a lot motivation for studying in future.
Great. Dimitro, what are you expecting from the course? What is your expectation? Maybe others can speak after you as well. Pelin, please be ready to speak after Dimitro.
I hope that I can find a lot of new information for me and make a new.
This is great. And I'm trying my best actually to transfer whatever we can do during just 30 minutes to you guys. But I think now we have Professor Khami, our moderator. Professor Khami, the stage is yours. We are ready to start.
Okay, thank you, Professor Nekufar. I would like to say hello to everybody, to all the participants in this course. I'm so glad and honored to be the moderator of these sessions. One session today and one session tomorrow. During the last, maybe I can say 3 months, I could see how the efforts by the team, that dental students team here, that they try their best to plan this course and make it as useful as possible. Okay, so in the first day of our course, our spring course, I'm so glad to introduce Professor Nekufar. Of course, he does not need my introduction, but he is the associate professor in our endodontics department in the School of Dentistry, Tehran University of Medical Sciences. At the same time, lecturer in Cardiff University, UK. I have been lucky to be a student of Professor Nekufar. I can remember what he has learned us. It was around 25 years ago, but I can still remember what he taught to us. Okay, so I think we should not waste the time. And Professor Nekufar, thank you for your presence in this course. Thank you for accepting our invitation. I'm sure that all the participants will benefit from your valuable lecture. So the floor is yours.
Thank you very much, Professor Khami. You make me very old. Can I be your teacher? I don't think so. I don't think so. Okay, I'm still young, guys. Okay,
I'm so young.
I really prefer to see your faces. If possible, any of you can turn on your your webcams. Then I feel I'm actually with you, face-to-face communication. That is much, much better. First of all, let me, because Dr. Khami told me that this is a spring course. Is it a spring course, Dr. Khami? Is it?
Yes, exactly.
Let me show you some of the spring in Iran. Can you see my background? This is the spring. This is the beautiful spring in Iran. So join us anytime and enjoy the weather and enjoy the beautiful scene of Iran. Because the time is not is very limited for me. I cannot stay in this beautiful area for you. So I'm going inside to start my talk for you. So that's it. This is the spring, and we are going to start the spring course from Tehran University of Medical Sciences. And obviously we are going also to share with our colleagues from Kharkiv University, Kharkiv Medical National University, which is an amazing time. So it is not the first time actually we work with each other, and we are very proud and very happy working with your university. Okay, so what am I going to speak today? And unfortunately, I should speak a bit quick because of the lack of the time. First of all, I may introduce some material or some device. I deny any conflict of interest and have not received any kind of payment for introducing dental materials and equipment in this presentation. So today I want to speak a little about the multidisciplinary approach and the decision-making in save it or extract it. As you can see here, you can see some of the fixtures and implants adjacent to the root canal treatment that I have done. So should we keep them as well, or should we extract them and insert implant like that? Or again here as well. So you can see my work adjacent to the work of a periodontist who insert these fixtures very, very professionally. However, sometimes we may think, why not try to save them? So this patient referred to me, and with actually acute pain here, acute pulpalgia, and also preapical disease, to suffer from urgent situation. Usually when you deal with one tooth, it may be easy to decide, but we don't need to do that. We shouldn't decide immediately by seeing just one picture or even one complaint from patient. When we have an area like that, area without a tooth, we need to decide about the holistic approach. We need to decide what we want to do. Definitely this time, we need to make sure that we are saving a tooth, we are inserting a fixture and replacing the edentulous area, because without replacing the edentulous area, you are not able to bring back the function of the masticatory system to your patient. Therefore, we call it multidisciplinary approach. So I want just to ask a question, and I can see some of the faces that they may have seen this image. I will ask them to not to answer my question, but for some of you that is the first time that you see this case, you may help me by telling me what to do for this patient. This patient referred to me by an orthodontist, and they asked me to do something for this patient. Just maybe one or two of you can help me for that. Just let me select one of the faces. I can see. All right, is there any volunteer to raise their hand to tell me what is their decision for this case, what they want to do with this case? If there is a volunteer, they may raise their hands or turn on their microphones.
Sorry, Doctor,
Okay.
can I talk?
Yes, please, Noor, go
Hi,
ahead.
how are you doing, Doctor?
Not bad, thank you very much. Go ahead, what do you think? What should we do for this?
Doctor, here in the lower first molar, there is a cyst. and this is like it's the apex of the roots.
Okay, resorption. Okay.
Yes, doctor. So, and also the bone also showed here, the bone also. So if we will extract this, tooth, we can't put implant. Yes.
Yeah, that's a very, very good point. Okay, so the question is, save it or extract it? Keep it as it is, do a root canal treatment or extract it. Okay, next one, please. Go ahead. Turn on your microphone quick. Yes.
Hi,
yes,
Dr.
please.
Do you have my voice?
Yes, yes, clear.
I think because the resorption has spread more than 1/2 of the tooth length, we cannot treat it with RCT. So the best decision may be to extract it because we see a lot of resorption here.
Okay, I want to ask one more volunteer. Dimitri, what do you think? Yasmin, whatever.
No, I agree with the previous speaker about the taste of the roots, and I think it's extraction of the tooth.
All right, Armita, what do you think?
Hello, I guess that is it possible to use MTA to save the tooth?
Another thing, possibility of advanced techniques. But I was waiting and expecting a very important question. What is the problem with this tooth? Nothing. This is the history. If you look back to the history of this case, you will see an impacted tooth that was removed surgically by an oral surgeon very carefully. Nothing happened except this area. This area is just the area of an impacted premolar that surgically must be removed for the orthodontic treatment. Please look at that very carefully. Now, so the first question must be the history. So if you want to do a planning, you should know the dental history of the area, even the medical history. After that, as we can see, this is because of the eruption and because of the crowding of this premolar, a resorption happened in the mesial canal. The tooth is not mobile and the tooth is sensitive. In terms of the vitality or sensibility test, the tooth is sensible and vital. So what should we do? Nothing. Just wait and see. And if you wait and see, such a things may happen. Wow. What does it mean? That means we shouldn't rush to the treatment. We shouldn't interfere with the treatment at all. If we see such a thing, we shouldn't jump to the conclusion, extract, or even save it. Using MTA, root canal treatment, regenerative endodontics, surgery, all of them are wrong. Noor just told us a very important thing about the bone. Bone structure is very important always. So when you want to decide about anything, first of all, think about the bone structure. If you want to do a treatment, extraction, think about the consequences of extraction. Consequences of extraction may be loss of the bone, or if you want to do even surgery, periodontal surgery, crown lengthening, you may sacrifice adjacent teeth. So be very careful when you want to design or plan your treatment. That is the first thing that I want to tell you. So the take-home message, everybody, the take-home message from this slide, the first slide that I showed you is, don't rush to the conclusion. Don't do the treatment just quickly based on what you can see in 1 or 2 radiographs. Always do the periodontal probing test. Always do the sensibility test. Always look at the history of the patient and decide what to do. Ahmed, do you have any question? Please go ahead quickly.
Yes, yes, dear professor. What about the follow-up of this patient? I mean, after how long did like this tooth?
This happens after a year. This happens after a year. And I did a very close-up monitoring of this case every 3 months. And every 3 months, I was looking at the sensibility test. I checked that, I probed that, and I was somehow worried about the consequences. And when I see the the bone formation, I was very happy. Therefore, this patient now is under the orthodontic treatment without any interventions or any treatment. Obviously, make out of it. Obviously, if I do some sort of treatment, I can make more money, but money is not the issue. We need to think about the health of our patient. Okay, sorry that I'm speaking a bit quick because today I just have 30 minutes. For this conference, I need actually weeks to cover some area of that. But it is just a taste of that. So after that, I may invite you to join us for our postgraduate course or for our future course to discuss more and more. Okay, let's have a look at this case. If we want to decide what to do for this case, if we look at the first premolar, we can see the plateal cusp is completely broken. However, the tooth may be restorable. The second premolar, the buccal cusp is broken. Maybe this is a little more difficult to save it because if we want to do a crown lengthening for that, we may sacrifice tooth number 6. However, tooth number 6 in the distal part may need also a crown lengthening. So crown lengthening may be justified. 7 can be just restored by composite or amalgam filling. So we need, first of all, to answer a series of very, very important questions. The first question for each of these teeth, can a tooth be effectively restored? Can we restore the tooth or not? If we can't, then we shouldn't do any heroic treatment. Because heroic treatment, I am professor, I am the best, I can do what, I can save whatever the tooth in the world. No, that is wrong. If the tooth is not restorable, we don't try. If the tooth is restorable, we should try. We must try, we must save. So this is a balance. So we need to be very careful. First question that definitely 100% we should answer is this: can a tooth be effectively restored or not? If not, extraction is the decision. The second one, will endodontic treatment be successful? Because sometimes you may have some obstruction inside the tooth, a broken file inside the tooth, a post inside the tooth that you are not able to remove it, a very large lesion from the buccal side to the plateal side with an obstruction inside the root canal. Obviously, endodontic treatment cannot be successful. You need to know the outcome of endodontic treatment. So for that purpose, you need to be a continuous student, always think about new publication, new courses, and think about that to cover all the new information to make sure that you are able to do a good and perform a very good endodontic treatment and successful endodontic treatment. You need also to answer this question for the same patient: is periodontal therapy feasible or not? If you look at this case that I put here, you look at tooth number 5 or second premolar, you will see that the periodontal treatment here a bit maybe dodgy because you may end up with some sort of problem. Or are you sure about the attached gingiva or not? So if you want to decide about the crown lengthening, you need to evaluate the attached gingiva, make sure that you have enough attached gingiva and run it. Otherwise, you are not able to do anything for that purpose. So these are the things that you need to be very, very careful about them and decide what to do when you want to actually start doing such a thing. Okay, is periodontal treatment feasible or not? The first question, if the tooth is going to become an abutment, imagine we are going to extract number 5, the second premolar, the one that I'm showing, then we are going to make a bridge rather than inserting an implant and a fixture. Then tooth number 4 and tooth number 6, are they suitable abutment for a bridge or not? We need to think about that. Do we have enough ferrule for that or not? If we don't have enough ferrule, then they are not good candidate as an abutment. So if we extract the 5, we need to think about the replacement technique. We need to think about how we want to replace the edentulous area. If you want to make it bridge, then we need to think about a suitable abutment. If we are going to insert a fixture, then that's fine. We can save the 4, we can save the 6. I mean, first premolar, first molar, and extract the second premolar, insert a fixture, make a crown on this because it looks restorable. We have 360 degree ferrule probably. For this one, we may have just 270 degree. We may think about marginal adaptation or coronally adaptation of the margins in the distal part, a lot of technique. So we need to keep ourselves updated to think about all of these questions. If we decide to extract a tooth, like the second premolar, we need to think about the consequences of extraction. Are we going to lose a huge part of the bone? Then we need to save the tooth. Very similar to the case that we showed, and Noor mentioned that we need to look at the bone. If we extract the tooth, maybe the consequence is huge. Therefore, we should keep the tooth comparing to the consequences of extraction, just for the healing of the bone. And if the healing of the bone happen, then that's fine. We can extract a tooth after that. Sometimes we save a tooth for a short time, maybe 1 year or 2 years, just to repair the bone, because the natural material is the best material in terms of bringing back the bone for the patient, rather than just put synthetic bone or surgical bone. Okay, we need also to know what are the alternative treatment available. This is also very, very important. What are the alternative treatment available? That is very, very important, because if we know, for example, other options, then we may decide what to do. That is also another reason for having you in our course, to tell you the alternative treatments. Okay, if we can't do an implant, what are alternative treatments? Huge number of alternative treatments are on the table, and we need to know them. Okay, so far we know what to do. The next question is, am I sufficiently competent to do such a thing? When I'm saying insert an implant, are you sufficiently competent? When I'm saying doing a root canal treatment for a curved canal, are you sufficiently competent? Or when I'm telling you doing a crown lengthening, or doing a mucoperiosteal surgery, doing a periodontal surgery, or whatever, are you sufficiently competent? Or for a complex restoration, are you sufficiently competent or not? Do you know the consequence of extraction very well? If you don't know, please keep yourself updated, especially during these times, which is very difficult to gain more practical competency. You need to keep yourself updated until this COVID-19 pandemic maybe reduced, to go back to the vocational training. As a dentist, you need a vocational training to be competent enough to do very complicated and challenging treatments. And also, it is very important to make sure that your patient is committed to good maintenance. That is very, very important. Because if the patient is not committed for that, and patient doesn't like actually to save the tooth, then what's the point to try? Well, obviously, what is the point to try? If you want to try such things, you need to do that. You need to make sure that patient is going to save the tooth and maintain the tooth in a very good situation. That is very important. And unfortunately, the last question that you need to answer is, can the patient afford the treatment options or not? I don't like this part, because I prefer actually to do always the free treatment for patients, but we need to live as well. We need to think about ourselves and also think about the material that we want to use. That is the problem, and that is a shame. However, I love the day that all the insurance company can solve our problem and cover the treatment options. But the important question that we need to answer is that as well. So have a look at this decision making. I'm sure many of them may say that, okay, that is not a good idea to extract these teeth, obviously. So the reason that this dentist decide to do that, because he or she may not think carefully and decide just to extract. And what am I, as a matter of joke, sometimes I called it bilateral pocketectomy. You remove the pocket of the patient or whatever is inside the pocket of the patient and put it inside your pocket rather than to treat your patient. So this is very important to make sure that you are not thinking about the business part of the treatment and economic part of the treatment, and think about saving a tooth if possible. Don't do heroic things. When it is necessary, do it. Let me show you some quick examples in the 10 minutes that I still have time. This patient referred to me after a myocardial infarction. And obviously, you know that when a patient just refer to you after a myocardial infarction, you cannot go ahead and do the elective treatment. So what I did, and the patient suffered from pain in the lower 7, and it wasn't possible to extract the tooth because of the myocardial infarction. So what I did, I started actually trying to bypass the broken instrument, clean the root canal system, put calcium hydroxide, put a temporary filling, and ask the patient to come back after his doctor lets me to start doing my treatment. Patient didn't came back, and when patient came back, it was after 11 months. 11 months even without the temporary filling. But surprisingly, you can see the healing at the preapical site. Why this healing happened? Because I removed the pathogens. I removed the pathogens from the root canal system, and I put calcium hydroxide just to get rid of the pathogens and bacteria from the root canal system. That is the philosophy of endodontics. If you get rid of the source of the problem, that is the philosophy of every treatment. If you can get rid of the source of any disease, you end up with the healing. So this happens for this patient. And I was able to save this tooth after 11 months because on the first attempt, I removed the pathogens and I removed the antigenic source which filled the root canal system. That is the most important thing. If I share the next case with you, same thing, because this patient suffered from pain in this area. And this pain was just because of the food impaction and because of this overhang. And patient was very happy after that. But this happened. So this tooth is not restorable. So don't do any heroic job after that. But you need to remove the caries to decide what to do. When you remove the caries and tooth is not restorable, and you know the consequences of your treatment, if you decide to do a crown lengthening, you may put danger for the adjacent tooth. Don't do heroic job if it is not restorable and if it is not necessary. But again, this time, look at this upper 6. This is a restorable tooth. So we decide actually to remove the post, remove the crown, and do retreatment or secondary treatment for this case. And it ends up with a good healing. Why? Because I removed the source of the infection. If you want to see that, for the second question, if endodontic treatment is successful or not, the answer is when you are able to remove the source of the problem, which is the bacteria, yes, you're able to save the tooth endodontically. So if I want to answer to this question and show you any case, will endodontic treatment be successful in this one? Even with this forcation problem that we already have in this case, the answer is yes, if we can get rid of the source. And in this case also, the retreatment worked and a good restoration put on the coronal part, the tooth survived for the patient. When we have a polyp like that or hypergeneration of the gingiva inside the cavity, we are not worried about that. We can remove that and save the tooth. If the tooth endodontically possible to be saved, even when you have 90-degree curve like that. So you need to make sure you are competent enough to do that. So if you like, join us, we teach you how to do that. Obviously, you need a good restoration. You need a good periodontal treatment after that. What about this one? This tooth just broken. And the patient was one of the professors of the university, and he couldn't go back to the university with this situation. But I told him it is not possible to restore the tooth. Because when I removed the broken file from the buccal side, it was 8 millimeters under the crestal bone. So it is not a good idea to do crown lengthening, because if you do crown lengthening for this case, you may sacrifice lateral and premolars. So I suggest extraction and maybe fresh socket implant and maybe put a temporary on that just for the patient to go back to the normal job, and don't do any heroic job when it is not possible. But when it is possible, and if you're not competent enough to do that, refer the case to somebody that they are competent enough to do such a treatment and wait for a good healing. So decision-making needs proper knowledge. Without proper knowledge, it's better not to touch any case. If you have proper knowledge, you're not going to extract such a thing. You're going to do a root canal treatment. Just wait and see to see what happened. Why this happened? Because we follow the philosophy of the treatment, which is removal of the pathogens, removal of the source of the problem from the root canal system. Then you're able to make a gallery like that and be very proud of your root canal treatments. I am actually showing off myself right now, but you're not going to refer any case to me from Ukraine, are you? But my Iranian fellows, I'm ready to have your patient. Don't worry about that. It's just a matter of joke. I'm fully booked for 3 months. Don't send anybody. Okay, so what about this case? Some surgeons, they put an amalgam at the apical side of these two teeth. Patient came back and referred to me by same surgeon with a sinus tract and fistula there. I decide to do retreatment because the philosophy of endodontics is to get rid of the pathogens from the root canal system. I fill the root canal system from the coronal part without any surgical intervention. Unfortunately, when I monitored the case came back to me again with sinus tract. So this time, when I look at that, when I compare the one that I finished with the puff of the sealer at the apical side, and this one, it shows that I don't have any apical seal. One of the things is when you get rid of the bacteria from the root canal system, you need to make sure that you seal the root canal system properly. So I decided actually to do a re-surgical approach as well and replace amalgam with MTA. Although Professor Bayat is here and he is one of the best surgeons in our country and even in many parts of the world, I am dare enough to show him some of my surgery. Sorry about that. I should refer that surgery obviously to him, but sometimes these oral and maxillofacial surgeons, they are very good in doing very large jobs. But for small jobs, when it comes to the microscopic level, sometimes they may prefer also to refer their case to us to do a surgical approach, but microsurgery on the microscope doing that. Another case, this is not my case. This is actually a case from Mahmoud Turabinejad, who is the developer of MTA. And we are very proud to say that the developer of MTA is an Iranian fellow, is one of the alumni of our university, Tehran University of Medical Sciences, and we are very proud of him. You know, he changed the approach of the dentistry by introducing mineral trioxide aggregate to dentistry in 1995. So you can see now by replacement of amalgam, by MTA, you can see a very good healing after a year when the coronal part is good, when you're happy about the quality of root canal treatment. When you're not very happy about the quality of the root canal treatment, the best idea is to do retreatment. Even if you have apical resorption like that, similar to the one that I showed you in the first slide, you don't need to be worried about that and jump for the conclusion and extract the tooth. If you're able to seal the root canal system, please go ahead, clean, seal the root canal system, wait for a good healing. You need to increase your knowledge about the anatomy. You need to think about the extra canals like this one. You can see the upper molar with the extra mesiobuccal canals. And you may do sophisticated techniques like the one that we did in this series of our research about the micro CT and looking at the internal anatomy of the tooth. By looking at the internal anatomy of the tooth, you may see a lot of delta, a lot of communication, and you can see a network of the root canal system, which is very difficult to make sure that you get rid of the bacteria and pathogens from this root canal system. You need to increase your background knowledge about the internal anatomy, and then you need also to know the techniques how to remove this bacteria from the canal. Obviously, by using the microscope and magnification and good illumination, you are able to do a better job in endodontic and surgical endodontic approach. When you do that, I'm going to give you another take-home message. Use the front reflective mirrors. And if you use a usual dental mirror, they are not helping you for endodontic treatment. For endodontic treatment, the best idea is to use front reflective and flat mirrors, because you don't want actually to see many images. in dental mirrors, we see a lot of images. But looking at the orifice of the canal, especially the second mesiobuccal of upper molar, you need these front reflective mirrors, and it gives you a huge, huge difference. When I start using this type of mirror, my life is changed. My life is changed dramatically. Okay, this is an example of doing a surgical treatment on the microscope, preparation of the apical part by ultrasonic. So you can see now we can go parallel to the long axis of the tooth, prepare the apical side, prepare the root end area, remove the bacteria from the root end area, and make it ready for placement of MTA or other biomaterials at the apical side. MTA, surgical endodontics, microscopic endodontics can be the topic of our future work. So please stay tuned for our future work, and I'm happy to start speaking about that. Let me show you some quick example of using MTA and MTA material for the apical side, so you can see the healing process after that as well. So let me finish my talk by, I'm just jumping from these slides, showing you extra canals in different anatomy by using microscope, how to find them, second mesiobuccal, second mesial canal from lower molars, like that, like this under microscope. Obviously, it is not very easy to detect them. There are a lot of techniques for that purpose. And let me go to my last slide. Don't do such a thing. You need to be competent enough to do root canal treatment and also prosthodontic treatment. This is absolutely in a wrong way. It shows that without enough competency, you shouldn't touch the tooth or such a thing. These are all wrong treatments. Why? Because the dentist hasn't got enough information about what he or she wants to do. The last slide. Think about always not doing any heroic treatment on such cases when you're dealing with a vertical fracture. Vertical fracture, unfortunately, is the candidate 100% for extraction at the moment based off of our knowledge that we have. But what you need to do a very good probing to detect that. Have a look to this case, the upper second premolar. This is after a retreatment. The dentist insert a post, unfortunately a large post, and patient came back with a sinus tract. The sinus tract was traced, and it shows that it goes to the apical side. So it can be a candidate for apical resection or apical treatment, like the one that I showed you. But what you need to do probing. You need to make sure there isn't any periodontal detachment, because if there is a periodontal detachment, if there is a periodontal defect, it helps you to decide not to do a surgery, not to running any heroic treatment. Obviously, if you do a heroic treatment, you may end up with the loss of a lot of bone. And as I said, you need to know the consequence of the treatment that you want to do. But because there wasn't any problem there, we decided to run the surgery. So what we did, we make the area numb. After injection, it is much easier to do walking and sound probing. This is the walking probing after profound anesthesia. Compare these two with each other. You will see the important things, because when you do that, when the patient is numb enough, you may find this narrow, isolated probing defect. This narrow, isolated probing defect is equal to the decision for extraction. So as you can see, I show you some cases. However, this gallery is full of cases. Next time or sometimes later, we may share this with each other. But when you have such a thing, you shouldn't do surgery. But this patient emphasized and asked me to do the surgery. I opened that, and what happened actually was to look at this vertical fracture. A true vertical fracture is not a good candidate for saving a tooth. And you can see now the loss of bone. So make the life of the oral surgeon very, very difficult for inserting an implant. This type of problems should be diagnosed earlier, and this type of teeth should be extracted earlier than these consequences. Okay, we are going to finish my talk. Sorry, Professor Bayat, for this some 5 minutes more than my time. Okay, so take home message. You need to answer this question before deciding any type of treatment. Can a tooth be effectively restored? Will endodontic treatment be successful? Is periodontal therapy feasible? Will a tooth be a suitable abutment? What are the consequences of extraction? What are the alternative treatments available? Are we competent, sufficiently competent to do the treatment? Is the patient committed for a good health, good maintenance? Thank you very much, guys. Hope to see you soon. Bye-bye.
Okay. Thank you, Professor Nekufar. Thank you for your nice lecture. Fantastic. I personally learned a lot. Still, I'm your student. And okay, and because of the time and without any extra word, I would like to introduce Professor Mohammad Bayat, again, one of my dear professors in Tehran University of Medical Sciences. He is an oral and maxillofacial surgeon.
Professor Bayat, Dr. Khami is trying to make us very old, to show us very old. We are much younger than him. He's trying to tell something like that. Don't believe him. He is not one of my students.
Okay. Okay, thank you. Professor Bayat is the head of oral and maxillofacial surgery department in our dental school, and also the head of the ward of oral and maxillofacial surgery in Shariati Hospital. And he has been the former dean of the dental school of Tehran University of Medical Sciences. And the title of his lecture is New Options in Functional Rehabilitations. Dear Professor Bayat, the floor is yours.
Professor Bayat, before you start, I'm going actually to tell you something about Professor Bayat. Yeah, Professor Bayat is one of the innovative surgeons in our country and is one of the innovative surgeons in the world. I'm telling that by enough confidence to tell you he has got his own techniques. He has got his own approach in oral and maxillofacial surgery. He has got a lot of patients referred to him from abroad just to be under his knife. I'm ready also to be under his knife anytime that he's ready to do any type of surgery on me. And I'm very proud to call myself one of his friends. Thank you very much. Professor Bayat,